his decision to settle, if only temporarily, in McGregor. So thanks again, Marc, for agreeing to share your presentation with us today. You have about an hour, but please reserve a few minutes towards the end for questions and comments. I'll also be tracking comments that we made online. Thank you, Marc. So over to you.
Thanks, Peter. Thanks so much. I apologize for not having my video on, but as you can see, I'm kind of in the dark here since my light's gone out. Thanks for that very kind introduction. I'm going to try and stick to 45 or 50 minutes so that there is time for discussion afterwards. As Peter mentioned, one of the things I'm passionate about is teaching. And this particular segment that I'm going to share with you today is something that I teach for the third year MVCHB class as part of a teaching case around childhood leukemia. And so the piece centers on the care of children and adolescents and their families who have a life-threatening condition. In this particular context, cancer and more specifically leukemia. And I attached the reading by Andrade, which I really love. And so I hope many or most of you have read that. And the piece, as you will know, speaks about the value of time. And when you work in this space, the one thing that becomes very apparent to you very quickly is that the two things in life that really count the most are time and the people who love you, whether that's by origin or by choice. And all the other stuff really is window dressing. And so he makes reference to that in his piece. And the line I particularly love that always strikes me is the line that says, "I want to surround myself with people who know how to touch the hearts of those whom hard strokes of life have learned to grow with sweet touches of the soul." And so if I can be that kind of caregiver, then hopefully I've achieved something for the people that I nurture in this space. So this presentation it unveils itself in 5 parts. And so I'm going to expand on them more as we go so that we won't take long here. But the 5 parts include speaking about knowledge, about compassion and empathy, about hope, about relationships and connection, and then to end off with a piece about the value of storytelling. So childhood cancer has moved kind of epically over the last 50 years. And to date, we probably cure about 70% of the children that we see in the cancer space. And that, I'm happy to report, is as much our experience here is in Cape Town as it is in most parts of the world. That cure comes after very prolonged therapy. So short in my world is 4 months. The boys on the chemotherapy spent 3 years on chemotherapy, so that's a very long time. And for those kids with brain tumors or solid tumors, they may or may not also need radiotherapy and surgery. But the flip side of that coin, of course, is that 30% of the children that we look after are going to succumb to their disease at some point during their cancer journey. Sudden death in cancer, in childhood cancer, is actually particularly uncommon. And so that normally happens after a very long time where we have gotten to know our patient very well and gotten to know their parents or caregivers very well, and sometimes also the extended family. So this is really old data, but it illustrates my point very nicely. And it shows the survival curves. This is from Red Cross, actually, over the last 50 years of the previous century. And you can see the monumental improvements that have been achieved in cancer survival. Of course, if you look at that post the turn of the century, those curves continue to go up, such that stage 1 Hodgkin's disease, stage 1 Wilms tumor, and certainly low stage non-Hodgkin lymphomas now enjoy 90, 100% cure rates. So catching childhood cancer early is a precept of the care that we provide. But those improvements, which have come because of international collaboration through international trial groups, through the ongoing improvements in surgery and radiotherapy techniques, the improvements in supportive care, particularly around pediatric intensive care and also bone marrow transplantation, come at a cost. So that last 10 or 20% that you see on those curves come at a price. And I've given 2 examples here. This is a paper from the Australian group that look at the psychological and psychiatric sequelae of childhood cancer treatment. So corticosteroids, for example, which is a cornerstone of treatment for acute lymphoblastic leukemia, has a list of side effects as long as my arm. We give kids about 60 milligrams per meter squared for 4 weeks in the induction. And that gives the parents back a child who is quite irritable, who has hyperphagia, who has quite rapid weight gain. Children who sleep poorly, have proximal muscle weakness, may get diabetes in the first month of their treatment, and also more prone to fungal infections. And then cranial radiotherapy, where the sequelae, unfortunately, are longer lived and include a whole list of endocrinopathies, but also cognitive and learning problems in children, even after they complete their therapy. So every patient comes in a context, and these readings come from our international society. So there's an International Society for Pediatric Oncology, and within that is a group that focuses on treatment approaches for children from developing countries. That's called the PODC, or Pediatric Oncology for Developing Countries. And there's a specific focus now to look at improving cancer survival in that group. And so as we telescope down out of that, and I mention it because we have to accept that the frame in which we provide treatment is limited by resources. So unfortunately, we don't work in an environment where we have everything that opens and shuts. And the truth is that some families are bounded by what they can afford in terms of access to more sophisticated or more expensive treatment modalities. And so as we telescope down now into the consulting room, we sit with a patient where, as you know, in your daily practice, doesn't only come with a medical concern, but who comes in a frame with language and communication issues, issues of comprehension, issues of their own cultural frame, their faith system, and also people who are bounded by their material wealth. And so those are all things that, as physicians, we take on a responsibility to unpack, certainly when we take a history from patients, to try and better understand who the person and who the family is that we are looking after. Because of course, in pediatrics, when you look after a child, you are by proxy looking after the entire family. So the second piece is about compassion, and compassion comes from the Latin root compassio, which means to suffer with. And so the critical question here for us is to ask, do we have the capacity to suffer with someone who has less than we do? Less money, and by proxy material wealth, who may be less well educated, may have less privilege. And I speak specifically of people who, for example, don't have their own transport to get to many appointments. In an induction block for leukemia therapy, the family have to come 3 or 4 times a week for chemo in one week. By secondary intention, those people enjoy less human rights, and in the specific context, also less health and well-being by virtue of their cancer diagnosis. So these psychological and concerns of coping manifest themselves through the chapters of the cancer conversation. And these manifest obviously a diagnosis and run through the various chapters that may or may not follow: remission, a relapse, if that is going to happen, the point beyond which pursuing any more curative treatment becomes futile, and we shift our focus in terms of the conversation of care, and then again at the time of dying and after death for the family who's left behind. And these emotions are myriad, as you know, but for the most part, parents or caregivers come to me completely flooded in guilt as they try to piece together the story of what they have done or left undone, which has brought them to this place. And so we spend many sessions in the first week. The diagnostic conversation does not happen in one conversation, where we bring parents back over 2 or 3 separate occasions in that week to go through the specifics of the diagnosis, but also to start unpacking the feeling space and getting a better sense of how this is going to impact our journey going forward. And for me, those conversations really rotate around two things. And for me, I've articulated them as personal and professional imperatives. So the question for me is, how do I balance the personal, which is the things that's important for the patient, versus the professional imperatives, which are important to me? And in terms of that first piece, how do I start to build a relationship with my patient so that it shifts the power differential in the room from being about you and me to being about us? And so I believe there's specific things that are really simple, that look simple on the page, but in practice can be a lot more tricky to navigate. But I think these things are critical. So you need to have an enormous amount of patience. Parents and children will bring into the room all of their pre-existing psychological trauma from whatever other experience they've had prior to their cancer diagnosis into the cancer space. And one has to start to try and unpick these as you work through the discussions around diagnostics and treatment. You need to keep your language really simple. That's as much for parents as it is for children, and I'll speak a little bit more about that later. You need to try and be authentically yourself, so children will smell a fake from 100 paces. And once you break a trust with a child, it can be enormously difficult to try and fight your way back to a point where trust is restored. One of the fundamentals or foundation pieces of that, of course, is that you need to tell the truth. So you need to be honest. And you also need to be open. And by openness, I mean that we need to try and be less and less defensive about people who come into the space with information. And that's becoming more and more a feature of our daily bread. People come into the room with their Google textbook. And so one has to also sit with that patiently and work through those specific questions and ideas and try and find a way through. And then from a professional perspective, you need to know your onions, right? So you need to have confidence in your training and in your competency. You need to know what the diagnosis is, what the treatment options are, and what the specific outcomes may be. And I was taught very early in my training to have the laboratory results in print in front of you before you have a conversation with parents. It's not always possible, but it helps to have that in the room. And then to understand, on the basis of what you're about to deliver to the family, what of those things are evidence-based, and what of those things, particularly in rarer diseases like bone marrow failure syndromes, are based on expert opinion or experience. So you need to come prepared, right? The preparation happens before the discussion, before the invitation to meet. And once the family arrives, there needs to be privacy and there needs to be protected time and space. So again, to the issue of trust. So trust can't blossom in an environment where everything that is known is not shared. And so my policy is quite simple with my parents. When I know, you will know. The contretemps of that, of course, is that sometimes we cannot know everything, right? That sometimes things don't always reveal themselves in the immediate moment. And sometimes we need to rely on time to provide us answers to some of the questions. But I think to also be honest with people that sometimes the answers to particular questions cannot be known, right? And so Rilke says this beautiful thing about living along some distant day into the answers, right? And so that line always rings true for me. And I once went to a coaching workshop where the person who was running it put it really beautifully and said, how do we walk together in our vulnerability to get to the same place when that place is unknown, which is very different from you walking to my place or me walking to yours. So hope is really critical to the cancer discussion. And I think the most fundamental premise of hope is that it isn't my place or anyone's place to remove hope from anyone, no matter how small we feel the avenue for hope is or how divergent my beliefs as a practitioner are from those of my patients. this paper from the oncologist really frames it very nicely, drawing a parallel between the trust or the faith that parents place in the oncologist and that person's ability to cultivate hope in the cancer space. And so does cultivating hope mean supporting unrealistic expectations? Well, I'll leave that question for you as grist for the mill, but one of the things which has really helped me in the understanding of hope is this paper by Catherine Weingarten, where she speaks about the concept of reasonable hope. So the first thing she mentions is that hope is something we do together. The second one I particularly love is that hope is a space filled with working, not waiting, right? So the idea that the heavens open and a light shines down, like the picture on the right-hand side, and that suddenly everything is made well again, of course, is not necessarily commensurate with reality. The third component is that things are influenceable, insofar as they may be influenced and not turn out the way that we'd anticipated. The opposite is also true, and I've seen that happen several times, and that's important to work through with patients, particularly when they're feeling anxious about outcomes. The fourth component is that we don't necessarily need to throw the kitchen sink at the patient, right? So not everything that can be done for the patient is necessarily better than the one thing that needs to be done. And that's a real critical issue, something that one of my colleagues.
Yeah, can you put something together? That's two students now.
These ones are actually organic.
Oh, okay. Okay.
Can I go on?
I think you can go ahead, Mark.
I think Sandra has perhaps muted you, Mark.
Oh,
There we
hi.
go.
Am I back again?
You're back.
Can I speak?
Yes, please.
Can everyone hear me?
We can. You were muted.
Oh, okay. Sorry about that. All right. I'm not sure where I left you off, but the last component of this Weingarten idea is that it accommodates doubt and despair. And so one of my dads said once to me, it's the hardest thing for me to accept that I have to give my child chemotherapy, which is going to make him really sick in order to make him better, right? And so that's the constant paradox that parents who have a child with cancer have to live with. So I really believe that we can teach, in this specific case, young doctors to cultivate emotional boundaries which help them to better connect with themselves, rather than as a way to disconnect from their patients and to keep people out. And I think there is a difference, right? We have this old traditional idea, I'm not sure how pervasive it is now, but it certainly was when I trained, of this idea of gravitas, you know, of doctors kind of floating 4 feet off the floor, and about their opinions being uncontested, and creating kind of a power hierarchy with their patients. And so that idea that we have to be bounded in that way, I think, is up for contestation. And that's particularly important when you are talking to children and parents about something as fundamental as a cancer diagnosis. So when I'm speaking to children, often we start by referencing mom and dad to know how much the child may or may not understand about the diagnosis before we do that. Obviously, parents have to participate in that discussion. It's been my experience, actually, that the vast majority of parents, or probably more than 80% of them, want to have the discussion about the cancer diagnosis with the child on their own. It's really a very small percentage of parents that ask me to do it on their behalf. And then the difference of those would be me sitting with the parents in the consulting room and chatting to baby about their diagnosis. For kids who are younger, again, explanations need to be simple, and not only for the under sixes, but for everybody. The things that we fear the most, it doesn't matter how old you are or what your illness is, are pain and separation, right? And so you need to be honest about procedures that may be painful and explain how that discomfort is going to be ameliorated. But you also need to provide comfort for the child and reassure them to let them know that mom and dad will be in the room if and when some of those things happen. With older children, explanations are a little bit more concrete. They want more information. And again, especially for an older child who may be more verbal, the emphasizing of hope and that the treatment is likely to make them better is a really important component of the explanation. I always use the word cancer when I speak to kids. It doesn't matter if you're 4 years old, your ears are completely functional. And so kids are listening in all the time. And I usually start by asking them what they understand by that word. And most of them, with very few exceptions, would have heard the word cancer. And that's a place for us to start. And so it really doesn't matter what their specific understanding is. It provides a point from which you can move to launch your discussion. Again, I mentioned that we want to say that the treatment is going to help him or her to feel better, but that it's probably going to take a long time to do that. And then we leave things open and provide the child with some space to ask questions. Mom and dad normally have lots of questions. I find it quite useful to let kids diarize their questions. The younger children tend to, not all of them, but certainly the majority of them tend to be quite shy. And so what they find fairly helpful is to write down whatever questions they may have and then to bring it into the consulting room. That's also helpful for parents, actually. And I have lots of parents who come with a little A5 handbooks. And as we sit down to start the session, take it out and off we go and work our way through the list of questions. Teenagers, as you will all know, are a different challenge. So I don't need to tell any of you that a teenager with cancer doesn't stop being a teenager. And so all of those struggles that they are having to navigate about identity, about independence, about body image, about acceptance, are things that get superimposed on top of their cancer diagnosis. And so that can be really, really difficult for them. And one of the things which really helps them is to give specific information and to give them as much say in some of the choices that they can have as a way to try and develop some agency. Of course, teenagers will differ. So some 13-year-olds are 10 years old and some are 17 in terms of their intellectual understanding or in terms of their maturity. And so one has to work also with a child that you have. It's not purely based on their chronological age. So my contact with parents and kids is really very simple. I always tell the truth. If you ask me a question, you get a straight answer. And obviously, one doesn't want to generate anxiety for the child. And so you have to be both age and developmentally and emotionally appropriate. They want to know if things are going to be uncomfortable or painful. For the parents, those things are also important. Also sometimes necessary to underscore to certain parents that their children are the patients. And that is the person to whom I have a medical legal responsibility to act in their best interests. And so sometimes when the answer is no, it's not about them and it's certainly not personal. And also that we're walking the road together. I don't know how the story ends. I never know that, but I know that we do it together. And that's a reassuring and comforting thing to be able to guarantee for families. And then especially for dads to make the point about asking for help, before the train hits the wall. Outside the hospital, of course, there are lots of things that go on for kids, particularly around school. Children who are high achievers academically have extreme anxiety in the ward when they're away from their peers and away from learning. And so we try and do as much as we can to facilitate the learning in the hospital. We have a great a school teacher who comes to keep children up to date with their lessons, makes contact with teachers so that we can continue that space as much as possible. And of course, with technology now, it's possible to Skype into classes and to visit friends and do other things which help to make the children feel more connected. Of course, they may have problems once they leave school, so absenteeism is an issue. Their cognitive abilities are an issue. If you are running a hemoglobin of 6 and you weigh 50 kilos, that's a problem when you're trying to concentrate. It's a problem if you're having cranial radiation. And then the other issues about body image. So you can imagine having a very obvious exophytic lump on your chest or in an area where there's likely to be skin exposure, or if you're an amputee, or if your surgery or radiotherapy gives rise to an obvious difference in your body dimensions. So that's really hard. That's over and above the hair loss issue, which is a whole separate issue to navigate on its own. So remission time is a time of less tension, where people are happy to have finished treatment. For girls, 2 years of therapy for leukemia, for boys, 3 years. So that's a very long time. And in this space now starts to emerge other things which have been shelved or suppressed in order to get the family through this time. And those things will range from financial pressures to marital discord to problems with other siblings. And so this now arrives in the space and is something that as a team we need to offer support with to try and get the family through. We follow these kids up for 5 years after their therapy is complete. And that is standard for all tumors. So a lot of the brain tumor patients will be followed up until we transition them into the adult space. So relapse is obviously a very stressful time, in many ways, far more traumatic than the initial diagnosis. Parents will say, well, we followed the protocol, we did everything we were supposed to, and now we've arrived at this point, right? And so one has to kind of make room for that. I think one of the most difficult things to do is to have a discussion around whether a second remission is possible. Sometimes it is, sometimes it is not. The road for therapy in relapse is always much more difficult, more intensive chemotherapy, radiotherapy if you have not had it first time around. And for leukemia, certainly will mean a bone marrow transplant. So the landscape is now much more difficult. And of course, all of those things are going to impact on family life. Of course, if a second remission is not possible, then the conversation needs to shift away from cure and to elaborate more around how we're going to pursue time as a goal for care rather than a treatment outcome. And so this is a particularly difficult space for parents and for the child. And we speak really about how to limit now visits at hospital unless they're absolutely necessary. If we're in a palliative frame, the palliative space can take on lots of forms. So because you are in a palliative frame does not necessarily mean that you will not be offered either an intensive or non-intensive chemotherapy option. It may include radiotherapy. So it's still a space where there are treatment modalities. But you have to now balance that very carefully against keeping the child at home for as long as that's possible and keeping them well for as long as possible, and trying to really limit both the visits to hospital, but also the intensity of the options that you are offering. Because of course, if you offer an intensive option, you may spend 4 of the 8 months that you may have left in hospital as an inpatient, receiving inpatient therapy, which of course is not a desirable outcome for the family. This space is also very difficult for parents. There's often an insistence on second opinions. I always say to the students, seeking a second opinion is your responsibility to facilitate. I think it does far more damage when parents are set free to seek second opinions on their own. I think a primary physician should take on that responsibility to point people in the right direction, and certainly to ask for opinions from colleagues whom they trust. I think that's a far more useful way to navigate that space. The other thing that often happens is that mom and dad are not matched in their journey to accepting the inevitable outcome of where things are going. And that almost always causes disharmony between mom and dad, or between a single mom and a grandparent, if that's the structure of the caregiving space. And so those things need to be carefully managed and supported in a very specific way, so that we can help everybody to arrive at the same place. If that's going to be possible, it isn't always possible. So you all know this work by Kubler-Ross. This is a seminal work from 1969, where she describes the stages of grief that people navigate through. And I think we all know from our work that these things don't happen in a seamless or sequential kind of way. And that particularly patients and parents will jump back and forth between whichever stage they need on a particular day as a way to try and cope from sunrise to sunset. So important that you may have to revisit conversations. You may feel you've done those explanations, or you've spent that time with the family, and they come back the next visit and you kind of feel like you've gone back, but that's unfortunately part of the journey. It's also a time when, in fairness, as doctors or medical practitioners, we tend to occupy more of the background space. And there are other people that now become important or prominent, people in their faith space, people in their families or communities whom they trust, who are able to offer comfort and support in a way that perhaps we are not able to do anymore. And it's important to bring those people into the space. We often have people of faith or alternative practitioners come into the ward for our inpatients to provide private spaces of prayer, of meditation, and of ritual that are important parts of families kind of moving towards a point of accepting where they're going. So what of storytelling? Well, everyone loves a good story, and kids are really masters of good stories. And it's a way for them to kind of reinvent themselves in heroic ways. And it also serves very importantly as a memory piece. And so when I have to sit and speak to kids about death and dying in particular, then it's always useful, I find, to draw a parallel between stories, right? That every story has a beginning and an end, but it's the piece in the middle, it's how we write the content in the middle and how we impact the world that sets us apart from everybody else. And that's a useful vehicle to use for any age child to help them understand the concepts, which are often complex, in particular issues around life and life after death. So those can be tricky to navigate. So to that end, this is something I wrote, and I'll read you the second part, which says, all manner of metaphor and drawings find their way into my conversations with children as we make our way through the complex and often frightening land of cancer, chemotherapy, and life. I use stories as a way to document journeys, as evidenced by the sea of dinosaurs, action figures, and animals that adorn the walls of my consulting room and my office. These are my memory tree, as a way to say to you, you are noticed, you matter, you are important. So speaking to children about dying has probably been one of the biggest, biggest learning areas for me in my practice. Children are tremendously deep. They have a sense of knowing about their own bodies, which really shouldn't surprise us, I guess, and about their life and what they're moving on to, if that's what they believe. That is really amazingly profound. And they've taught me the kinds of things in my conversations with them that one would struggle to find in a book anyway. And I recall a specific conversation with one of my 12-year-old patients whose parents weren't able to speak to her. She had been treated for leukemia, she had relapsed, had a transplant, and her disease had then come back again after her transplant. And I went to sit with her in her room one afternoon, and we started chatting. And I said to her, have you thought about where it is that you would like to die? So this was obviously after some time. We didn't jump in with that as a first question. And she looked at me and she said, I want to die in G1 in hospital, right? So that's where I work at Red Cross. And I said to her, wow, that's really interesting. Most of the people I speak to want to die at home. And she said to me, well, I've thought about it. And what I don't want is for my folks to walk into my bedroom at home and for that to be the last thing that they remember about me. And that was really profound because it helped us to shape the space at end of life for her in a way which kind of honored her dignity. And so because we'd been brave enough to have the conversation and to ask, and we knew what she wanted, her parents brought her to hospital, you know, when she was on her last, and we literally put her down on the bed in the day room. And as they did that, and they were sitting with her, she passed away. And that was really tremendously healing for mom and dad when we came back several weeks later to speak about the conversations we'd had and whether we had, or particularly they were asking me whether they had done things in a way where they had done everything that they could for their child. That was the first question. But had they done everything in a way that honored who she was? And so those things, those conversations become very powerful tools to help healing after children have passed on, because of course that is the work that needs to happen, right? So whether the child is there or not, the healing still has to happen for the people who are left behind. And so one tries to be there when the day comes, when the moment comes. It obviously depends on a whole lot of logistical things, which we all are aware of. But in particular for patients whom you are very connected with, who have had long relationships with, being present on the day or in the moment where the child dies is very profound. So Raja Kool talks about bringing a person free of words and actions, right? So just about presence, it's just about being there. Students often ask me, you know, it's not something I'm comfortable with. I don't want to do it. I don't know what to say. And I say to them, well, there really isn't anything you can say. And really what's required is for you just to be, rather than to feel compelled to say anything. And that's really important for parents. And the level of comfort that you have in terms of how demonstrative you are or are not, in terms of the physical affection you may show for people in that moment, is also a function, number one, of your relationship with the parents, but also a function of your own sense of self-awareness and what your boundaries are. So you obviously need to allow parents time to be with their child. And then also remember that in that moment, as insofar as it may be very emotional, is you still have a clinical responsibility to help assist with the administrative things. Death certificates need to be completed. Patients need to understand what the process is once the child has died. And if there's going to be a home death, then usually what we've done with the palliative care team when we worked out an end-of-life care plan is that we've contacted the general practitioner, who then comes to the house and certifies the body then for burial from home. So it's not always possible to go to every funeral. We try and go. That again is a function of logistics and also a function of what you can and cannot manage emotionally. You will all know that sometimes you are at a point yourself in your work where attending a funeral may not be something that you have enough reserve to do. It's my practice that I will contact the family immediately, if the child has died when I'm not here, and then set up a discussion for them to come back and speak to me in 4 to 6 weeks' time. And those discussions take on different shapes depending on who the family is. So some people want to come for a single discussion, for an exit discussion, a final explanation, in order for them to have closure and to go. Some people cannot come back. So you can imagine walking over the threshold is just something that that's too much for them to do. Some families leave in anger, which is very hard for everyone, including the physician. And some families I've had the privilege of supporting for sometimes 12 or 18 months after their child has died. And that's taken on different shapes. So many of them were, again, not able to come to the hospital. And so we decided on a venue mutually where we could sit and have discussions. And everybody's journey to acceptance is different. You never recover from the loss of a child. It just never happens. One of my moms said to me, over time, I've learned to make it smaller and to take it out on particular days and to be with it. And it was really beautiful. But losing a child is not something that as a parent you ever separate yourself from in any kind of way. So I'm smart, I'm knowledgeable in my field in which I'm considered an expert. I understand the treatment I will offer patients, the possible outcomes, and whether there's existing evidence or expert opinion to support these recommendations, and I come prepared. I'm compassionate, I listen to my patient, I walk with them. I do not lead, they do not follow. Much easier said than done. We arrive hand in hand, I suffer with them. I co-create hope. There is togetherness in hope. Hope is work. Hope accepts that life is messy and that outcomes are often full of uncertainty. I understand myself in relation to others. So I understand, shape, and use my personal and professional boundaries in my own and in my patient's best interests, but not as a way to be disconnected from them. And I'm part of every story, as part writer and part player. I value your story. It means something to me. I listen, I reflect, I respond. So I just wanted to end off with something about about balance. And Peter mentioned in the beginning that one of my other passions in my life is music. And so music's been a way for me to achieve that balance. And when you work in an environment where you watch children die, you struggle with the cruelty and senselessness of that, no matter how much you know. And so the music's been a way for me to process my feelings around my own mortality. It's also, which I guess is a fairly important part of being an oncologist, I guess. But it's also been a really powerful way for me to say goodbye to children that I've cared for and loved. And you do love the children, whether you like it or not. And it also has been a vehicle for me to become more spiritually awake, which I think is really important. So I have a little video I want to play for you, and I think we have enough time. It's just 5 minutes. And it's something that I wrote for a patient who I lost after a bone marrow transplant, and which a friend of mine in Australia has illustrated and animated for me. And the song is called Storybook. And it's about, if you can imagine, a child recalling the scenes of their life as a set of photographs over the course of time. And so I'm going to play it for you, and then we can take questions at the end. Boat races, chasing the sun that ends the day, treetops and endless games, the sunset frames, good night, blue skies and kites, puppies and candy-coated sighs, smiles at the next array, and the games we played, the fights. You brought the sun with you, I brought my heart. The light that just shone and shone and shone and
shone right from the start. Why did you go? Why can't you stay? Just so I know. Time leaves today, and the moon and the stars have spoken, and storybooks are open. Hot air balloons, paper jets, every old folks' tunes, card games and Christmas times, and nursery rhymes, and friends, tiptoe stones on the lake. Shooting the breeze, we've made mistakes, but we could say so what? Because the love we've got, it's great. You brought the sun with you, I brought my heart. The light that just shone and shone and shone and shone right from the start. Why did you go? Why can't you stay? Just so I know. Time leaves today, and the moon and the stars have spoken, and storybooks are open. Every smile, galloping fun, we told the sky. Every hello, swallows in flight, laugh as we go, say your goodbye. Paper boat races, chasing the sun that ends the day. Treetops and endless games, the sunset frames. Good night. Good night. Good night.
Thank you. So the floor is open for any questions, if you have any.
Thank you very much, Mark. Thank you for leaving a few minutes for questions. I'm trying to see if there are any hands being shown. John Parker, I see your hand.
Thanks. Thank you, Mark. Sure, your compassion just shone through that whole talk. I wanted to draw you a little bit on kind of the importance of hope, but there seems to be, there's often this clash between beliefs and evidence. And often, I think this is particularly relevant with the whole vaccination thing, but often, the evidence is to some degree uncertain. It's complex. We can never say you'll definitely live or you'll definitely get better. And often belief offers that or appears to it, and often there's this faith challenge. So if you have enough faith, then your beliefs will come true. And how do we, I think it's a challenge to all of us is how do we teach people how to check facts, how to you know, how to understand evidence without shattering hope.
Yeah, I mean, I think it's incredibly difficult. I think, like for all of us, there have been specific patients where despite your best efforts to try and do that for people, you know, parents make their own decisions about what they will and won't pursue. I think for me, it raises the very difficult question about how to manage that space medico-legally and ethically. So we've had a handful of occasions where we've had children with treatable disease whose parents have decided not to present them for care, or at least the care that we were offering, and sought help in other places. Some of those, in my recollection, were faith-based, some were not. In some cases, those children have then died at further afield, or they have returned to us once their disease has escalated to the point beyond which cure is no longer possible, and then we've had to palliate them in that space. I think the real challenge that we have when we are facing a question of whether to go a medico-legal route, which, remember, in this case, so you need to think about this, you're telling a family their child has cancer, they make a decision not to accept your care. You then, in terms of Section 28 of the Act, are actually obliged to act in the best interests of the child. And sometimes that may mean that you need to get an order from the court to remove that child from the family, to then insist on treatment. Now, that's an incredibly difficult thing to do, right? None of us as pediatricians ever want to find ourselves in a position where we are removing a child from their parents. And you can imagine the younger the child that is, the more heart-wrenching, the more difficult that becomes if baby is 2 or 4 years old in a time where being with mom and dad is absolutely critical. So I think our approach has not been to pursue a medico-legal route. Of course, it makes it much easier is the wrong phrase, but it makes it easier to do when you feel that the prospect of cure is not something that's easy to attain. It's much harder when you feel that you may have given that child a legitimate chance. But you're weighing that against separating a child from their parents and causing disruption in a family in a way that I think is infinitely more damaging. So, you know, those are the things that keep us awake at night, you know. So for the most part, the convincing happens, and I think people it's frightening. Chemotherapy is a really frightening thing. You know, you give the stuff, I mean, it makes you sick. And it's only kind of 3 weeks, 4 weeks in that you see this child re-emerge in the way that you know them before. And then you go, wow, right? So it kind of turned out the way he said, and maybe there's some merit in it. But for some people, the anxiety of having to walk that road and to wait for that is too much for them to bear. And I mean, there are kids, and I know their names, and I can see their faces where, you know, like I say, you lay awake at night and wish that things could have been different or that you'd made different decisions. But it's an impossible place to find yourself in. It's not just as easy as somebody says, well, get a court order and just remove the child. I mean, that sounds like a technically very correct thing to do, but it's the repercussions of that are absolutely profound. So, I mean, I don't think that's an answer to your question. Yeah. It's more a statement of the impossibility of life, right?
Mark, there are 2 more questions. Yeah. Sharon Kleinkies has a question, and then Renee after Sharon.
Mark, thanks very much. I'm glad you had that question first, because it gave me time to compose myself after your very profoundly evocative presentation of your work. Thanks so much. What struck me in your slide about fundamentals is, you know, we bring our expertise, we try to be compassionate. From a recovery point of view, creation of hope is essential. self-knowledge and accepting that we should be part of the story rather than disconnecting ourselves. And I know in our faculty transformation document, we highlighted the kind of practitioner that we want to be growing, the one that you've described through your work. And I just wondered if you had some thoughts for us around how we could start that process of enabling practitioners from all the health professions to move towards that empathic, centered, knowledgeable, and interactive and relational stance that you've described today.
Yeah, look, I mean, the one thing I will say that I think's made a difference in me learning those particular skills is that I was trained by a person, and I'm speaking of the emeritus Professor Barry Hartley, who trained me, who was an expert at those conversations. And so I learned at the feet of that woman who was incredible. And so insofar as there are things from books that you can learn and frameworks and guidance documents and all of those things, the kind of skills that you acquire when you're actually sitting in the room with a family and being taught and guided firsthand by someone who really is magnificent at being able to do that, I think is critical. So I think we've, in our busyness to do everything and be all things to all people, that sometimes falls by the wayside. And so particularly the difficult conversations around diagnosis, around end-of-life care for our senior residents are critical pieces that they actually sit in the room with us and learn from people who are more experienced at doing that. So I'm a firm believer at, and then having a conversation and debrief with those people, with that student immediately afterwards. So to say, how did that conversation go? What are you feeling? What pieces do you think went well? Do you think they understood what we were saying? And just get a sense of whether they were actually taking notice of the non-verbal touchstones that were going down, not just the content pieces. So I think it's about the way that we teach. I love teaching. So I think it comes naturally. I think for people who may not enjoy teaching, it may be a little bit harder. But I always say to the fifth years, learning has to be fun. If you're not relaxed, if you're more worried about the person who's teaching you being horrible to you, and that's the reason why you don't come for teaching, for example. And it's those kinds of things where this relationship with learning starts, right? I remember having teachers at university who terrified me so much. I never used to come for teaching. And that's a terrible thing to admit, but it is true. And so it's important, I think, when we deal with young people to make them feel relaxed, to make them feel that they are smart, that everybody needs to contribute to the learning conversation. It's a style of teaching. And it also, I think, is really helpful once you've done the content piece of your teaching. I often take them to look at the scans afterwards, and then I tell them the story about the family. And I make the point to say, look, so we spoke about a patient today and an examination, and we spoke about pathology, but remember, therefore the grace of God goes you. So that person in the bed is a person, and they have a life and a context and a story. And you need to be cognizant of that. These are not just pieces of pathology that float in and out in front of you. So I think if you want to cultivate practitioners who are aware in those ways, you have to teach in a way that brings them in, that makes them interested. I had a fifth year once who was not interested in medicine. He made it very clear to me he was only doing it because his parents had forced him. And the minute he graduated, he was leaving. And he came to me about a week after we had a tutorial, and he said to me, I really hate medicine, but I really want to say to you that the afternoon we spent with you was one of the most interesting and engaging experiences that I've had in the 6 years I've been there. So, that's not to blow my own horn, but it's about making the point about the way that you engage the students and teach them creates a little kernel of interest and learning and a desire to be inspired and to learn in a particular way. And so we need to nurture those things. If we want the product to be what we all talk about it being. You have to start in the beginning. And the best way to do that is to start when the kids are in third. As early as you encounter them, that's when you start that piece. And then you grow them from there. That's the only way we're going to get it done, I think.
Thanks,
Mark, we have time for one last question. I see that there's a question from Renee.
Hi, thank you. Thank you very much, Mark, for your talk. I wanted to ask about the psychological and psychiatric aspects and what your team does to gain support for the families. There is a consultation liaison service provided by the Division of Child and Adolescent Psychiatry, but often Red Cross Hospital kind of has to make additional provision because the need is probably so much greater than what a little service like that can provide. So I just wondered if you could share what usually happens when there is that.
So in 2012, we kind of realized our numbers were really going up very fast, and we realized in that very dramatic escalation that one of the pieces that were falling off that we were not doing as well as what we should have was the psychosocial support. So we've actually started a psychosocial group, and we have a meeting every month, and that consists of the consultants, the fellows, nursing staff, Peds who have their operations across the way at Rondebosch Medical, so a family counselor, social worker, palliative care physicians. We have 3 clinical psychologists who join us from private and an art therapist. And we have used that meeting so we've had it CPD accredited, and we use it as a teaching space for the fellows, but we've also used it as a case referral meeting. And it includes the pastoral care service from the hospital. And that has made a massive difference in the kind of support that we're able to provide. And our social worker, sorry, almost forgot, very important person. And so together as a team, we look at the specific child and the specific family and the needs that they have, and then we're able to pass the pieces to the people who are best placed to provide the kind of support that we need. That's really been a piece of magic for us over the last 5 years. And, we've regularized our system to a point now where the referral and where the kind of co-support for the families works really, really seamlessly. We've used the referral system, I think, in psychiatry and mental health more and more over the last 12 to 18 months. And so I've benefited personally from working with people like Papani and others who've been absolutely amazing in kind of assisting us to put those pieces together. But you have to, we'd have no full-time clinical psychologist at Red Cross. I don't know if anybody knows that, but there's no such person. If you consider the massive stuff we do here, organ transplants, bone marrow transplants, you name it, right? Not one full-time clinical psychologist at Red Cross, which is staggering. Right. Anyway, that's the truth. And so we had to take lemons and make lemonade. So we looked at all the people, the partners that we worked with, and we said, can we come together and make this meeting and make this team as a way to kind of support care and provide a better service for the kids. So you have to think outside the box. You will have formal pathways you can use, but you have to try and bring partners in. And people have come on different funding streams, so we've kind of been lucky. We've been able to piece those things together. But it's a lot of work, but it's really worthwhile. And I think that 5 years down the line, or more than 5 years down the line now, we provide a really comprehensive care package for kids, apart from just their cancer care. They get the kind of psychosocial support, which is not as readily available to children and families in other places. So it was just a matter of seeing a problem, having agency, bringing people on board and saying, let's turn this around. Let's make a space where our care package is more comprehensive and where the patients and their families are winners. And so that's how we did it.
Thank you.
Mark, well, it remains for me just to thank you once again for your wonderful presentation, and to thank all of those of you who took the time to attend. Mark, you might want to have a quick glance at the comments. There are a couple of very, I think, gratifying comments for you.
Oh, thank you.
And thank you very much. And we'll
Thanks, Peter.
certainly like to keep in touch with you and your work.
Yes,
Thank
thank
you.
you. Thank you so much all for coming. I really appreciate it. Thank you so much.
Right.
Thank you.
Bye-bye, everyone.
Bye.